So Todd Molfenter worked with the Chess Center at the University of Wisconsin, where we do a couple main areas. We do a lot of organizational change work that has primarily focused in the behavioral health area and specifically addiction. And then we also do a lot of workforce development work that that I'll explain to you a little bit here. A lot of the work we do around organizational change looks at this issue of ways to get people into treatment quicker and then keep them in treatment and prevent no-shows and things like that. And so I'm going to do like a 10-minute just drive-by on some of the things we do and how it works. So next slide, please. Just as a disclaimer, I'm also involved with a group called the NIATX Foundation. They do consulting work around this. There's really no overlap with what I'm talking about today and this work. And also I have a conflict of interest plan with the university that sort of keeps an eye on all these efforts. Next slide, please. And we mentioned this earlier. I'm talking to you from what we call the suite of TTCs here at the University of Wisconsin. We have the Great Lakes Addiction Technology Transfer and Mental Health and Prevention Technology Transfers, which means we do workforce development training and education across a 6-state area that spans from Minnesota down through Wisconsin, Illinois, Indiana, Michigan, and Ohio. And anything like evidence-based practices, workflow issues, retention, staff retention, patient retention, things like that we're involved with. Next slide, please. That's our funding stream, SAMHSA. It's SAMHSA funded. And so talk about NIATX a little bit. Next slide, please. Yeah, NIATX began back 2004, 2005 through support through the Robert Wood Johnson Foundation and SAMHSA itself. Over the pursuing past 15 years, we've worked with about 3,000 organizations working in this approach. We found it to be very helpful, and now there's about 30 plus peer-reviewed publications on how this sort of organizational change model works. And like I said a little earlier, a lot of the work it does have to do with wait times and no-shows, but we're also over the past 5 years, a lot of our work has been around MOUD implementation. And specifically buprenorphine and injectable naltrexone. Currently, we have projects looking at doing that, a couple statewide initiatives. Currently, we're working with 20 jails around the country on ways to increase MOUD initiation within the jail setting and continuing its use and continuing care. And also work with health systems quite a bit. Things we focus on is increasing capacity as far as ability to be able to provide the prescribing, do the ancillary tests, things like that. Looking at ways to increase referrals and active use. And a lot of our work right now actually is focused on retention issues, keeping people on their MOUD. And other things we are looking at or just involved with is reducing no-shows in telehealth. A lot of folks had a really good initial activities around telehealth. They're continuing to do it, but they're seeing no-show rates go up as they're doing that. So we're doing projects around that. And then we have a project we just started here a couple months ago around improving case management utilization. Involved with that is quite a bit of peer recovery support kind of services too. Next slide, please. So NIATX, basically, the whole approach, you can find it on the internet at niatx.net. And how it works is anything that you can measure, you can improve, and that's sort of how we sort of structure how we do the approach. Next slide, please. So how it works, it's a pretty simple model that we work with people on. As we work with them, we really stress certain what I call administrative evidence-based practices. We really work on getting a project team together that has a change leader, clinical champion, and some team members that are willing to dedicate some time to the project and the issue. Have an executive sponsor who makes that time, endorses that time. It's not data like in a research sense, but it is data in sort of just understanding how the issue you're looking at is either getting better or worse. What we do from that is ask people to run sort of these small experiments around these plan, do, study, act cycles or tests or pilot tests sometimes, and then just have them measure what they're doing as they do that until they get the results they want. And then we do talk quite a bit about sustaining the changes and appreciating about 50% of organizational changes are not sustained. So ways to do that. Next slide, please. So just a quick example. We were working with a health system last year, and they were wanting to get more referrals into the behavioral hub from spoke primary care providers, and ran a series of cycles to be able to accomplish that or improve the referrals into the hub. First thing they did was some education with the different primary care clinics. A part of that education was to increase prescribers and getting their X waiver. But quite a bit of it was just education of things to look for, when and how to make referrals and things like that, and really getting into some of the issues that you talked about on this past case. And so start with that, sort of really making the environment a little more receptive to identifying referrals and making them. And then the next cycle is around, well, hey, once you need to do a referral, let's talk about how that's going to happen, making it so it's as seamless and easy to engage in and do as the patient and as the different providers involved with the process. And so that was the second part of that. There was some complaint about, hey, we have someone available and it takes 2 or 3 weeks to be able to get an appointment, or we have trouble reaching someone, at the hub site. So really looking at, this is where some of those wait times and no-show kind of changes came into play again, and looking at ways to, improve those referrals. And then, so once they got a little better, making it so that the referrals were quick and the like, then there was some concerns about, I'm still not sure about, when's the best time to refer, when I'm looking about how many drinks they providing some mentoring was the next thing they did. And then after that, then the physicians are saying, well, hey, we don't always know what happens, to the referrals we've made. And so then they developed a plan of being able to provide some feedback of how the referral's progressing, what actions are happening. And then for people who are actually put on MOUD regimen is, over time, being able to transfer that person back to the primary care practice so they can do some of the, do the maintenance monitoring with the person. So that's just an example of a kind of project. There's really, like I said, anything that you can sort of in an organizational setting you can measure, and you can apply this approach to, and really right now where we're seeing a lot of interest and just a lot of need is just around retention issues. a lot of people entering regimens, just for a short period of time and then stopping. So I think just being able to, do some work there to, provide case management supports, address side effect issues, things like that, has been helpful with the retention piece. But is there any questions?
Eventually, I'm going to have all kinds of questions, but I really loved your presentation today. Thank you very much.
Well, thank you.
This sounds exactly like what we're doing with the Hub and Spoke project through UW right now.
Yep.
I'm a peer support specialist on there, so I'm wondering, if some of this might be helpful and beneficial for our team as well. We are dealing with a lot of, no-shows and cancellations, which then trickles down to the provider not wanting to reschedule them appointments. So as a peer support, I have that ability where I have been reaching out and asking them, like, what barriers do you have right now? What fears and concerns do you have making it to your appointment? And trying to spark that conversation. And then maybe, this program, or I'll do more information on it, could help with that referral process too, because we do refer to the hub and then, we refer back. So
all that's really needed. And as you've noticed, it's not easy. Those handoffs aren't easy. Keeping people aren't engaged isn't easy. And so that's where a lot of what we do is just try to find some ways to make that work better. I mean, there's certainly no no magic bullets per se, but there are ways to sometimes make it work better, which it helps a few more people, which makes all the difference.
Oh, it has been. We've been live with this project for about 2 months now. And, I think we helped maybe like 30 people already. We got a good team. We have behavioral health registered care coordinators that reach out, get the appointment set up. So we're just trying to get immediate access for MOUD medication in primary care.
Yep. And what can help with that too is just any data that you can sort of keep on an ongoing basis. I mean, obviously you have your observations, but to have the data too can just help know how you're trending, help when you ask for more money, things like that too, or just want to demonstrate the benefit of what you're doing.
And that's exactly the point. And the good part about this presentation is that's what everybody is asking. Where's the data? Where's the numbers? How are we collecting this? How are we looking at this to, show that we're being successful, which we are.
Yeah.
There's nothing in place right now, so.
Yeah, and just be, I mean, I do research. You can really overdo it with data. I know that too well. And just if you can find some basic, just a few basic measures that can help you, and you can use it as for your internal meetings even. That would be probably a great start for you.
Say thank you, Dr. Molfenter, for this introduction. I've been sort of looking at the website as you were talking, and there is quite a lot on the NIATX website for people who are interested in learning more. I might take a look.